Good evening, everyone. I am Dr. Jayal Shah. I am a professor in Department of Cardiology at Cce-Unmicrc Institute of Cardiology and Research Center. So today we will have a discussion regarding endovascular upper extremity interventions. So we will just start with the normal anatomy of aortic arch, upper extremity, and some anatomic variants. We will also discuss the differential diagnosis, and then we will examine the application of catheter based techniques for the management of arterial diseases of upper extremities and proximal aortic arch. So to start with, this is just the normal anatomy of the aortic arch with normal branching patterns of vessels coming from the aortic arch in approximately 70% of population. So the right brachiocephalic artery divides into right subclavian and the right common carotid artery behind the right sternoclavicular joint, and the arch further divides into left common carotid and then the left subclavian artery. So this is a right subclavian arteriogram which shows the normal anatomy of the right subclavian artery and its continuation and its different branches. So right subclavian artery becomes the axillary artery at the outer border of the first rib. Then at the outer border of the teres major muscle, the axillary artery ends and it continues as brachial artery, which divides into foramen, into upper, into brachial and ulnar and the radial artery. So ulnar artery continues in the hand as the superficial palmar arch, while the radial artery continues in the hand as the deep palmar arch. So different branches which we are able to see in the subclavian arteriogram includes the costocervical trunk, the dorsal scapular artery, thoracoacromial branch, superior thoracic artery, suprascapular branch, circumflex humeral branch. So these are the different branches of the subclavian and axillary artery which we have to keep in mind while this endovascular intervention. So these are the different anatomic variants of the aortic arch and subclavian artery. So the most common one is the bovine arch, which is the common origin of the brachiocephalic and the left common carotid artery, which is most common but having no pathologic significance. Other important variants are origin of left common carotid artery from the brachiocephalic artery or origin of left vertebral artery from the aorta. The other important one anatomic variant is the origin of right subclavian artery from the aortic arch distal to the left subclavian artery, which is also known as arterial lusuria, which is having pathologic significance because it might lead to compression of esophagus and dysphagia, and sometimes the compression due to esophageal ring also leads to the aneurysm formation and which is prone to rupture, which is also known as Comerel's diverticulum. The less common variants are the common origin of carotids and origin of radial artery from the brachial or axillary artery, and similarly origin of ulnar artery from the brachial or axillary artery. So this is just the pictorial representation of the most common anatomic variant. This is the bovine arch. So in this case we can see that there is a common origin of the brachiocephalic and the left common carotid artery, which is having no any significant pathological significance. The second one, which is more common and associated with more pathologic significance, is the aberrant origin of right subclavian artery distal to the left common carotid artery. So this is known as arterial lusuria and it is a common cause of dysphagia because of compression of esophagus. Sometimes the proximal segment has a propensity for dilatation and aneurysm formation, leading to formation of Comerel's diverticulum and compression symptoms. So coming to the history and physical examination for upper extremity vascular diseases. So in that case, your history and review of symptoms should be very much comprehensive and should include a detailed description of the symptoms, the comorbidities, the exposure, the trauma, and the complete medication history, including the prescription drugs, illicit drugs, as well as tobacco usage. And the keys to the narrowing of differential diagnosis include the consideration of the previously described elements, the acuity of onset as well as the temporal variation, the exacerbating and the relieving factors, the symmetry of symptoms, as well as the examination findings. So to be summarized, unilateral symptoms suggest a more localized process, whereas bilateral symptoms are more characteristic of a systemic process. In a vasospastic disease, the intermittent or the constant nature of symptoms help to differentiate between the primary Raynaud's disease from the secondary, which is the obstructive variant. And the blood pressure should be manually measured in both the arms, because a systolic gradient of greater than 15 to 20 millimeter of mercury suggests a significant stenosis, while a gradient of more than or equal to 20 having a specificity of 94% for occlusion. So blood pressure should be measured in all the four extremities to evaluate any differential pressure readings between the extremities. Coming to the physical examination, palpation is very important. Palpation should begin in the supraclavicular fossa, because any pulsatile mass suggests a subclavian artery aneurysm. Then tenderness in the supraclavicular fossa and along the scalene muscles also suggest the thoracic outlet syndrome. Then all the digital and arteries of the upper limb should be palpated, because any pulse deficit suggests the possible pointers to the etiology of the disease. And the supraclavicular fossa should also be auscultated for the presence of any bruit or murmur. Similarly, a bruit suggests a subclavian artery stenosis, while a continuous murmur suggests a arteriovenous fistula. Similarly, the skin should be inspected for any ulcers or any rashes, petechia, purpura, or any cyanosis. An examination of nails for pitting, as well as the nail bed capillary loops or splinter hemorrhages, which suggest the vasculitis or endocarditis respectively. So what are the signs of arterial ischemia you encounter during your physical examination? So in the case of acute arterial insufficiency, different signs like pulselessness, pallor, poikilothermia, pain and paresthesia will be present. While if the process is a chronic one, then it will be accompanied with muscular atrophy, skin bronzing, focal hair loss, as well as digital gangrene. And non-healing ulcer will point to either acute or a chronic disease process. So what are the different differential diagnosis of upper extremity vascular disease based on your history and physical findings? The different one for medium to large size arteries are atherosclerosis, aneurysm, thromboembolism, entrapment, vasculitis or vasospasm, each having a specific set of symptoms and a specific symmetry as well as acuity. So in the case of atherosclerosis, it is typically a unilateral disease which is chronic and more or less progressive. If it is an aneurysm, it is also more or less unilateral, chronic and progressive. However, if it is a vasculitis or a generalized arteritis, then it is associated with constitutional symptoms, as well as the process might be either unilateral or a bilateral. Similarly, in the presence of vasospasm due to any exposure to drugs, there will be a digital pallor as well as cyanosis, and the process might be either unilateral or bilateral. Similarly, the other differential diagnosis for small vessel disease of upper extremity vascular diseases include certain hematologic disorders like cryoglobulinemia, myeloproliferative disorders, leukemia, multiple myeloma, as well as macroglobulinemia. Certain hypercoagulable states, particularly APLA syndrome, antithrombin or protein C protein S deficiency, or HIT syndrome. Then certain rheumatologic diseases, particularly rheumatoid arthritis, SLE, scleroderma or HS purpura is one of the important differential diagnosis. Similarly, certain infectious diseases like hepatitis C or mycoplasma pneumoniae, or certain embolic or thrombotic diseases, particularly Buerger disease, atheromatous disease, atrial fibrillation, atrial myxoma, as well as certain vasospastic diseases and exposure to vinyl chloride, which forms an important differential diagnosis. So coming to the workup for a patient with upper extremity vascular disease, we can start with a segmental limb pressure measurement in the vascular laboratory. So it is the most useful initial test to determine the level of obstruction, particularly when the symptoms are asymmetrical. So the blood pressure differential usually normally between the side is less than 10, but if the gradient is more than 20, it suggests a significant obstructive disease, while a gradient of more than 30 suggests an occlusion. Similarly, from this we can confer the wrist brachial index or the finger brachial index, which if less than 0.85 or 0.70 respectively, it indicates arterial insufficiency. So this is just the pictorial representation of the finger pressure waveforms from photoplethysmography. It is an excellent technique for differentiating the obstructive and vasospastic disease. So you can see in the most upper image is the normal arterial upstroke. So it is normal arterial waveform. So in that case, there is a rapid systolic upstroke, a sharp systolic peak, and a dicrotic descending notch is there. Similarly, in the middle one, it is an obstructive disease pattern which shows the reduced amplitude, decreased slope, and loss of a dicrotic notch. Similarly, if there is any vasospastic disease like Raynaud's disease, there is a secondary ascending peak which is also known as nipple sign, which is an important diagnostic marker for Raynaud's disease. So this is just a brief overview of the different tests which we undertake for the diagnosis of upper extremity diseases. We have already discussed the wrist brachial index, segmental pressure measurement, and photoplethysmography. The next one is the duplex ultrasound, which is highly sensitive and specific, but it is highly operator dependent, and the accuracy of it is limited. So in that case, the CT angiography scores more because it is a higher resolution which allows the visualization in multiple planes, and it is more or less an objective test, and but the disadvantage is because of radiation and contrast exposure. Similarly, magnetic resonance angiography is an excellent anatomic modality for diagnosis of upper extremity intervention, but there is it is time consuming and it requires prolonged breath holding, as well as it cannot be used in the presence of metal, particularly if the old generation ICD or pacemaker are installed, then particularly limits the usefulness of magnetic resonance imaging. The last one and more definitive is the catheter based angiography, which allows direct visualization of vessels and the upper extremity anatomy. It is invasive, associated with contrast and radiation exposure, but it helps in excellent visualization. So what are the indications for aortic arch and upper extremity diagnostic angiography? So when you encountered a patient when there is a blood pressure discrepancy of more than 10 millimeter of mercury between different arms, or history of radiation therapy from neck and chest, history of vasculitis or known peripheral arterial diseases, in the evaluation of certain acute symptoms, particularly acute limb ischemia, blue disease syndrome or cyanosis. Similarly, after blunt or penetrating trauma with signs of vascular injury, for evaluation of symptomatic arm claudication, or for evaluation of unilateral upper extremity embolization is suspected, or for evaluation of possibly suspected Steele syndrome, which can be either a subclavian Steele syndrome or a coronary Steele syndrome. So for the catheter based angiography, before selecting, we are taking or starting the aortic angiogram using a soft multi-site hole catheter, particularly a pigtail, and almost 30 to 40 ml of contrast material is delivered with auto injection at in a 30 to 40 degree alleo projection using a DSA, which should be ideally performed. The recommended contrast media is iodoxinol, which is an isosmolar non-ionic agent. So for the catheter based angiography, the access is typically obtained from the common femoral artery for the catheter based angiography, and for percutaneous intervention for stenosis. However, if we are dealing with an occlusion, then in addition an ipsilateral brachial artery access in combination with CFA access is a must. And for selective engagement and angiography of the brachiocephalic and the left subclavian arteries, the various catheters can be used with hand injected contrast of 5 to 10 ml on DSA. So most commonly the Judkin Wright 4 catheter is selected, but alternatives also include the Lima or Rima catheter, multipurpose catheter, or specially shaped catheters like Vitek, Siemens 1, 2 or Headhunter 1. So this is the just a brief guide on how to select the catheter on the basis of anatomy of the aortic arch. So whenever all the origins of the major branches of the aortic arch lies within more or less same plane, it is a type 1 arch. When the origin of major arteries lie more than 1 but less than 2 mm diameter of the common carotid artery, it is type 2 arch. But when they are originating at a wider width of more than 2 diameter of common carotid artery, it is a type 3 arch. So particularly JR4 catheter is appropriate for type 1 arch, while a Vitek or a H1 is recommended for type 2, and a SIMS is an ideal catheter for type 3 arch. And due care should be taken while engaging, disengaging or manipulation of catheters to avoid the vascular trauma or to avoid excessive scrapping of the aorta, which might lead to atheroembolic phenomenon and cholesterol emboli syndrome. So for the catheter based angiography, so as far as the projection and views are concerned, the orthogonal oblique projections are ideal for the proper delineation and for reduction in the overlap. The RAO view is particularly recommended for brachiocephalic bifurcation, origin of right subclavian artery, and origins of left vertebral artery and IMA from the left subclavian artery. While the left anterior oblique projection is particularly recommended for right vertebral artery and Rima. So common projections are LAO 30 degree for origin of great vessels and RAO 20 degree for brachiocephalic bifurcation. The important point to remember is that patient positioning should be neutral, but some abduction and external rotation may be needed for the evaluation, particularly when thoracic outlet syndrome is suspected for causing vascular compression. So for axillary and brachial artery angiography, the diagnostic catheter should be placed in the distal subclavian artery and anteroposterior projection with the patient in neutral position, although slight arm abduction may enhance visualization, and sometimes digital subtraction angiography in this views is recommended. So management of upper extremity disease ranges from medical management to percutaneous intervention to surgical management. Modification of risk factors and medical therapy for atherosclerotic disease remains central to the standard care of management. And when any intervention is indicated, the percutaneous management is all favor over the surgical approach because of the improved efficiency and patency rates with percutaneous interventions in the modern era. Before initiating a brachiocephalic or a subclavian intervention, the diagnostic images should be studied to determine the proximity of the lesion to the vertebral, carotid and internal mammary arteries, as well as know the angle of vessel takeoff. And assess for the percutaneous intervention is typically obtained from common femoral artery, particularly for stenotic lesion. And if we are dealing with an occlusive lesion, then ipsilateral brachial or radial is taken in combination. If a CFA access is prohibited with severe aortoiliac disease, then brachial access is recommended for the treatment. So, what are the different tips and tricks for the intervention treatment of upper extremity disease? Is a long sheath or a guide based system should be used. The sheath or guide should be parked just proximal to lesion, taking care to avoid the atheroembolization. Balloon expandable stent, which are more important for osteal lesions, should be used for stenosis proximal to the vertebral artery, while self-expanding stent, which offer more flexibility and less deformability, are typically used to treat stenosis which are distal to the vertebral artery. And because of the risk of dissection or rupture, a conservative stent sizing is recommended. Typically it is 6 to 8 mm for the subclavian and 8 to 10 mm for the innominate artery. So this is just the pictorial representation of the stent placement. So the left sided image shows the pre-stent lesion, which is in the proximal left subclavian artery. In the middle image, it is the image of the deployed stent, and on the right is the post-stent angiogram, which shows the patent artery. So after stenting, lifelong aspirin and at least 4 weeks of clopidogrel is recommended, with suggested follow-up intervals of 1, 6 and 12 months. And bilateral cuff pressure should be taken at every visit. Symptom recurrence or a more than 10 mm gradient should be evaluated thoroughly. Another important disease which we are today is discussing is subclavian steal syndrome. So it is basically the result of reversal of blood flow in the vascular territory supplied by the subclavian artery, because it is characterized by retrograde vertebral flow away from the cerebral circulation, and symptoms are directly due to vertebrobasilar insufficiency or upper extremity ischemia, and they are worsened with the use of extremity or with the compression of vertebral artery, which is such as head rotation. And estimated 2.5% of patients with subclavian steal syndrome are symptomatic, and 80% of them are having concurrently contralateral carotid or vertebral artery stenosis. It has a threefold higher incidence in the left subclavian artery stenosis compared with the brachiocephalic, and is twice as likely to occur in 40 to 60-year-old men compared to the women. And talking about the different etiologies of subclavian steal syndrome, the most common one definitely is atherosclerotic. Other are the thoracic outlet syndrome, which is common in athletes such as baseball pitchers, swimmers, golfers, in which there is a vigorously and a repetitive abduction of upper extremity. Certain congenital heart diseases and certain iatrogenic causes, like particularly prior radiotherapy for malignancy or prior surgery such as CABG, AV fistula creation for HDXS, BT shunt repair or TOF repair. So for the treatment, it is reserved for symptomatic cases only, and primary success for stenting is achieved in 98% of cases, and complication rate is less than 1%. So as far as the prognosis is considered, the long-term prognosis is excellent with regard to progression of neurologic symptoms and other symptoms, but prognosis is usually dismal, where particularly when atherosclerosis is the cause. And as far as the Takayasu is concerned, the prognosis is benign compared to atherosclerosis. So coronary subclavian steal syndrome, which is another variant of steal syndrome. So in this case, coronary ischemia results from the shunting of coronary blood retrogradely through the internal mammary artery to supply the arm with the proximal stenosis in the subclavian artery. So patient in this case typically experiences a typical angina pectoris on exercising the arm. So it is typically seen in those patients who have undergone CABG with internal mammary conduit and who have proximal subclavian critical stenosis or occlusion. So in that case, catheter based intervention is the first line therapy for symptomatic patient, and it gives excellent result. So this is the pre and the post subclavian arteriogram of the coronary subclavian steal syndrome, which shows the definite benefit of stent placement. Now another important variant which we are discussing today is the thoracic outlet syndrome, which is a very common entity but underdiagnosed and quite undertreated disease. It encompasses a heterogeneous group of disorders that results in symptomatic compression of the neurovascular bundle at any of its exit point as it traverses the cervicoaxillary canal through the interscalene triangle and costoclavicular space to enter the upper extremity. So the neurovascular bundle which we are talking about consists of 5 roots of brachial plexus, the subclavian artery and subclavian vein. So it can be either neurogenic or vascular, which can be either arterial or venous. The brachial plexus along with the subclavian artery pass through the interscalene triangle bounded by the anterior and the middle scalene muscles, and the subclavian vein passes outside the scalene triangle, while this neurovascular bundle then passes through the costoclavicular space and then through the retropectoral space to enter the upper extremities. So the most common form or variant of TOS is neurogenic, which accounts for more than 95% of cases, and it leads to compression of roots of brachial plexus mostly in the interscalene triangle, and it is having a female preponderance. While less than 5% cases are vascular, and in that the arterial is quite more common compared to the venous. So arterial variant is equally distributed among male and female patient, whereas the venous variant quite tends to occur more common in a male compared to the female. And site of compression is usually mostly an osseous narrowing in the costoclavicular space. Compression of subclavian artery at this point also results in the aneurysm formation distal to the compression. So what are the different causes of thoracic outlet syndrome? The most common are the bony causes and other are the soft tissue causes. The most common bony or osseous causes are the cervical rib, the T1 or C7 vertebrae, the dislocation of humeral head in the case of fractures, clavicle, cervical spondylosis and crushing injury to upper thorax. While certain soft tissue, particularly the scalene muscles, the omohyoid muscles or certain fibrous bends may also lead to outlet syndrome. So the symptoms of TOS usually present insidiously and it becomes progressively worse, and the symptoms include either claudication, pallor, coldness, digital ischemia, pain in the hand and arm heaviness, swelling of the arm, cyanosis and paresthesia also are the symptoms. So various provocative maneuvers can be used to elicit the symptoms, although all suffer from very low specificity. Some of the provocative maneuvers which are commonly used is the Addison's maneuver, in which the patient is sitting upright, takes deep breath, looks upward and turns his or her face towards the affected side. Another important is the East maneuver, in which arms are extended, externally rotated and behind the head, and then patient repeatedly makes fist for 3 minutes while the radial pulses are palpated. Another important is hyperabduction maneuver. Other is the costoclavicular maneuver, in which the patient thrusts both the shoulders maximally backwards and downwards. So diagnosis of TOS is very challenging. As we have previously discussed, it is an underdiagnosed and undertreated disease. No single test is there to prove the diagnosis of TOS. It is based entirely on clinical suspicion. So whenever the vascular TOS is suspected, evaluation in the form of imaging, particularly CT or MR imaging, should be done. Angiography should be performed initially in the neutral position and then it should be repeated in the provocative position. So this is the diagnosis of TOS, which is which is covered in the basically provoked position. So these are the MR angio imaging in the rest and in the provoked maneuver, in which you can see in the provoked maneuver there is a compression of subclavian arteries because of possibly a bony cause. So as far as the treatment is considered, it is reserved for the patient who are symptomatic or have evidence of embolization. Surgical intervention is considered for decompression in the setting of an acute vascular syndrome, whereas endovascular management using catheter directed thrombolysis or embolectomy can be used, and endovascular therapy is reserved for the second line treatment. So other different treatment which might be considered are the physiotherapy, certain lifestyle changes, psychiatric counseling, and certain medication which are commonly pain relieving medicines and muscle relaxant can be tried. Then anticoagulation and thrombolytics can be tried in certain resistant cases, while the definitive management are the surgical management, which either include the rib resection, clavicle resection, scalenus muscle transection, or embolectomy, bypass grafting, and at the very last, dorsal sympathectomy. Thank you.